Hello, everyone, and welcome to this special college education event. My name is Kelly Kane, and I am a nursing consultant with policy and practice at the College of Registered Nurses. My colleague and nursing consultant with policy and practice, Michelle Carpenter, is here as well and joins me in welcoming our special guest, Jeremy Harnum, who is a clinical pharmacist for the prescription monitoring program with Newfoundland Health Services Digital Health. And this education event will give a brief overview of the prescription monitoring program to help explain why the program was created, its role in addressing drug misuse, and the specific activities the program is responsible for. We will discuss the Prescription Monitoring Act and the requirements for the prescribers under the Act. We will review navigating HEALTHe NL's medication profile, including the new monitored drug tab, as well as answer some FAQs about HEALTHe NL, including the difference between prescriptions and dispenses and the different statuses, be active or aborted, etc., of each one. Hi, Jeremy. How are you?
Good.
So, Jeremy, what is the prescription monitoring program?
Yeah, so the prescription monitoring program is part of the provincial government's opioid action plan aimed at addressing the growing opioid issue. The purpose of the program is to help prescribers and dispensers make the most informed decisions when choosing to prescribe a monitored drug to treat a patient. And the program was established through the Prescription Monitoring Act. That act was passed January 1st, 2018, and the act outlines the responsibilities and the duties of the program.
Okay, perfect.
There we go. And so the program kind of consists of two components. The proactive component is going to be clinicians with that medication profile check, using that to make informed decisions before prescribing or dispensing a monitored drug. The retroactive component is what I'm involved in, and that would be evaluating report data for monitoring, analysis, and education.
So, Jeremy, you mentioned monitored drugs. What drugs specifically are monitored by the prescription monitoring program?
Yep. Currently, only opioids are monitored by the program, and that's been the same since the outset of the program. You can find a list of the monitored drugs on the PMP NL website under our FAQs. But essentially, if it's an opioid and it's written on a TRP, it's a monitored drug. Additional drugs can be added to the program in the future by the minister. But if that decision was made, we would communicate that in advance to all practitioners to make sure that prescribers and dispensers are aware of any change, but currently only opioids.
Perfect. And you mentioned TRP,
Yep.
tamper-resistant pad, right?
Yep, tamper-resistant prescription pad, which are the opioids are going to be written on. Now, other medications can be written on a TRP, but they won't be monitored by the program currently. So something like Ritalin, stimulants, they're going to be on a TRP, but they are not monitored by the program.
Perfect. Thanks, Jeremy. So what are the requirements under the Act for a prescriber when prescribing a monitored drug?
So before issuing a prescription for a monitored drug, a prescriber must review the patient medication profile in the electronic health record relating to the individual to whom the prescription is being written. Reviewing a local file in Meditech, an EMR, or a paper chart does not meet this requirement. So essentially, you have to log into HEALTHe NL, go to the patient's medication profile, and review it there. The second part of that is that you have to record that a medication profile was accessed in HEALTHe NL. And to aid in that, all the TRPs were updated with a checkbox that can be checked to indicate the check has been completed, and there's a spot for the date and time as well.
Okay. Is there anything else clinicians should know about the Act?
Yeah, upon the request of the minister, a prescriber, dispenser, or any other person shall disclose to the minister any information, including personal health information, the minister reasonably requires to achieve the objectives of the program. This requirement overrides any confidentiality provisions in the Personal Health Information Act. So essentially, if the prescription monitoring program reaches out to a prescriber and requests information, could be prescribing information that on a specific patient, it's going to include personal health information. Prescribers don't need to worry that they may be violating the Personal Health Information Act by providing that information to the program. The Prescription Monitoring Act covers that. And not only can you must provide that information that the program requests. And that the Act also gives the minister the right to disclose any information to regulatory authorities or law enforcement as well.
Great for that clarification. Thank you.
No problem.
So Jeremy, who administers the program?
Right. So initially, it was NLCHI, the Center for Health Information, but like all the health authorities, we are now part of NLHS. So basically, NLHS Digital Health administers the program.
And what's their role, in administering the program?
Right. So the program is delegated by the minister to administer the program, and we're responsible for developing and maintaining the program. And that would basically involve evaluating data stored in the pharmacy network and HEALTHe NL to track the utilization of monitored drugs. We're going to look at specific opioids, the rates of usage, analyze reports to investigate questionable activities and ensure compliance with the Act, promote appropriate opioid prescribing and dispensing practices, and inform prescribers, dispensers, and other PMP NL stakeholders of trends in opioid usage in the province. So we report quarterly to the department on the number of patients taking opioids for pain, the number of patients taking opioid dependency treatment, the number of prescribers who are prescribing opioid dependency treatment, and the number of pharmacies dispensing, along with other information that we're tracking in our reports as well.
So Jeremy, can you tell us what key information or criteria are used within the program to audit monitor drug prescribing and compliance?
Certainly. So that's like a key operational function of the program. That's sort of what our main thing we're doing is we're running reports regularly to check these questionable activities. And so there's 5 reports we're running on a regular basis. The first would be patients receiving 2 or more monitored drugs, so 2 or more opioids from 2 or more prescribers in a 30-day period. So we know there's lots of reasons the patient may legitimately have an additional opioid prescription. They're on chronic pain medication, and then they have a surgery done. But we're trying to track the activity of patients who may be seeking multiple prescribers from walk-ins and emergency departments, that sort of thing. So that's the first one. The second one, we're looking for multiple opioid dispenses from multiple pharmacies in a 30-day window as well. Again, there could be very legitimate reasons why a patient is using multiple pharmacies. Their regular pharmacy may have been closed when they had an additional opioid prescription. But we do know patients who may be trying to get opioids filled early, they're not likely to go to their regular pharmacy who may be very familiar with them, know that they're on an interval, they're only supposed to get it every 30 days and have that local file. So they're probably likely to jump to different pharmacies to see if they can, get a prescription filled early. So that's another report we're tracking. Dispensing opioids with no MCP number. So you would really only have an opioid dispensed without an MCP if you're not from Newfoundland. And that's certainly possible. People who are traveling to the province, there's definitely times that they're going to need an opioid dispensed. But what we're trying to do is ensure that we don't have patients from the province trying to create multiple profiles at different pharmacies so that they can't be tracked through the electronic health record for these multiple prescriptions at different pharmacies. That said, we rarely see, if ever, that kind of activity, but we still check just to be sure. Patients who are on opioid dependency treatment, like methadone and Suboxone, who are prescribed an additional opioid. Again, there's lots of legitimate reasons. If you're on opioid dependency treatment and you need surgery, you certainly may need opioids. But we just want to check to make sure if we're seeing additional opioid prescriptions for patients on opioid dependency treatment, that the prescriber who wrote that prescription was aware the patient was receiving ODT, that the ODT provider is aware of the additional prescriptions, and that the pharmacies are aware, that if it was dispensed at a different pharmacy, again, if they were aware that the patient was receiving opioid dependency treatment before they prescribed or dispensed as well. And then we look at opioid dispenses for large durations, like a 90-day supply. This report started in the beginning. Since COVID, we kind of seen some changes in how medications were dispensed just to reduce the number of visits to pharmacies and that sort of thing. But we've kind of seen a change back. And rarely do we see opioids dispensed for large day supplies. It tends to be for legitimate reasons like travel for work and that sort of thing. And the other report that we do run regularly would be to check to make sure prescribers and dispensers are compliant with their medication profile checks prior to dispensing or prescribing a monitored drugs. And traditionally, nurse practitioners had the highest rates of compliance with this compared to other prescribers, but it has been trending down in recent months. Last 6 to 12 months or so, we've seen a bit of a decline. So we will be providing the college overall compliance rates going forward to ensure that the rates are improving.
Right. Thanks, Jeremy. And we have provided some communication to nurse practitioners on their rates over the last number of years. So, and with the trending down, the rationale of providing the session today, just give the update on the MP requirements. So thank you.
No problem.
Jeremy, would you be able to take us through a demonstration of the HEALTHe NL medication profile tab?
Certainly.
But actually, and before you do that, Jeremy, if it's okay, there is a comment in the chat box, which I'm guessing you probably had this question before. It's about what they do sometimes if HEALTHe NL has been down or they're unable to access it due to computer issues or access issues. Is there, I guess, a plan or a protocol in place for when that happens?
Yeah, unfortunately, the way the legislation is written, there really isn't sort of a workaround in place. Technically, you have to do the profile check. Now, we've raised this with government because, there are, on schedule outages that do occur, that's unforeseen, and we would not want the program to impact patient care. So, if there was like an on-schedule outage and HEALTHe NL was down, and it was down for an extended period of time, and, you had a patient who needed an opioid prescription, we're not going to say don't provide an opioid prescription. What I would say is at the earliest time after you've written that prescription, make sure you complete the check after the fact. It's not in the legislation. Technically, you can't write a prescription. But again, yeah, if you had one of those situations where HEALTHe NL was down and it was an extended period and you had a patient who needed an opioid, patient care is going to, be top priority. So just do the check as soon as possible after. And like I said, it's something that's on the radar that needs to be sort of corrected because those unforeseen outages do occur. Yes. Now, at the same time, we've had questions about, well, what if, I'm going to see a patient and I can't, bring my laptop with me? Well, I would say, if it's sort of like you're seeing a patient at home or in a place where you don't regularly have access to HEALTHe NL, you would have to do the check before you left, right? And if you know you're regularly in those situations, that doesn't absolve you of the requirement to do the check. You have to sort of come up with a workaround so you can do the check before. The only time I would say would be like an on-schedule outage when there's absolutely no other way. But if it's sort of like a work thing where you're like, well, I'm going to a patient's home and I don't have a way to access HEALTHe NL while I'm in that situation, I would say do the check before you go. Even if you're not sure if you're going to prescribe an opioid, do the check before, so you've got it done.
Thank you, Jeremy. Can I just ask a quick question on that? Are practitioners able to access the profile on a mobile device?
Yep. HEALTHe NL, as far as I know, tablets and stuff that are that have access would to the internet, you'd be able to log into HEALTHe NL. Yep.
Okay, perfect. And just, I guess, I would, encourage nurse practitioners maybe to document in the client's chart if there's an outage, and then when they go back and check, in in the profile, yes, check it off, but I would say document that as well, that occurrence, so that there's a quality documentation on that the system being down.
Perfect. Thank you, Jeremy. So yeah, would you be able to take us through a demonstration of the HEALTHe NL medication profile tab?
Certainly. So here's our demo patient. So we're in staging here. So this is all just, not real patient information. So when we go into the patient, we can see there's a bunch of tabs across the top here. Patient summary, timeline, encounters, and medication profile. This is the tab you must click to complete your medication profile check. It may sound obvious, but I have had prescribers who were just going into HEALTHe NL, bringing up the patient here, and then exiting. And when I said you're not doing your profile checks, they said I am going into HEALTHe NL, but they weren't clicking on the medication profile tab. Now I don't know how they would believe they were doing a profile check without clicking on the tab. But yeah, you click on this tab and now you're in the medication profile summary. So our prescription summary is the first little window. Then we have two other windows, which are all prescriptions and all dispenses. I'll go through the prescription summary first. So we can see here, we can toggle between 4 months, which is going to bring up just the last 4 months of prescriptions, 12 months, and 24 months. Our status, I'll talk a little bit about status, but I would encourage to always have all 4 of those checked off. If you're just checking, if you're leaving any of those out, you're not going to get a complete clinical picture. I would always recommend having all 4 of those clicked on. And then we have this new sort of radio button here to change between all prescriptions and monitored drugs. So when we click this, we're now seeing only monitored drugs. And we can see here there's been an additional column added to the summary as well that indicates these are monitored drugs. So if we're back in the all types, we can see metformin, ramipril. There's no monitored. So even when you're in the summary screen, if you want to quickly scan if it's a monitored drug or not, we've got the little additional column here on the side. So we've got our drug, our tablet form, who prescribed it, when it was prescribed, and when it was last dispensed. And the dispense, last dispense is how we sort our prescription summary. So we start at the last dispensed and the most recent dispensed going to sort of the furthest away. We've got our status of the prescription, our direction, how many were prescribed, and how many were remaining. Now, a key point that I'll make is the prescription summary provides the most recent dispense of the drug and the strength. So we can see here, morphine sulfate, we have 1 prescription on January 15th. When we click on this prescription, now we can see down in the other tab, the all prescriptions window, here's each individual prescription for morphine SR15. So the second one here was last dispensed on January 5th. and the most recent one was last dispensed on January 15th. And if we look at the January 15th, if we click on this little scroll, we get the sort of prescription details. The directions are take 1 tablet at bedtime, in addition to other morphine doses. If we click on the 15 down here, which is still active, we can see it's take 1 tablet twice daily. So we've got 2 prescriptions for morphine SR15 and another prescription for morphine SR30. If we hit the printer-friendly version of the prescription summary, it might take a second for it to pop up, we might falsely assume that the patient is on morphine SR30, take 1 tablet twice daily, plus an additional 15 milligrams at bedtime. But when we click into the morphine SR15, we can see this additional prescription for morphine SR15 that the patient is taking twice daily, and it's still active. So really, the patient is on morphine SR45 twice daily, plus an additional 15 at bedtime. And so we have to remember that the prescription summary only provides the most recent medication and strength that was dispensed. The patient could be taking multiple sort of prescriptions for the same strength at the same time. And another good example, not it's a monitored drug, but lorazepam. A lot of patients take lorazepam 1 milligram QHS at bedtime regularly. They may have an additional prescription of lorazepam that might say lorazepam 1 milligram, take a half to 1 tablet every 4 to 6 hours as needed for anxiety. So depending on what one was last dispensed, it's only one of them are going to appear in the prescription summary. So you need to click into the individual drug to see all the prescriptions for that one. One other thing to mention is this information is supplied by the pharmacy network, and all community pharmacies in Newfoundland and Labrador are all connected to the pharmacy network. So when you go into a profile, you know you're seeing all the prescriptions for a patient, whether they go to just one pharmacy or if they go to half a dozen pharmacies throughout the province. All the prescriptions here are from all the pharmacies in the province. And that's why it's sort of impossible to have like, you know, a complete sort of this is what the patient is taking list in this display, because all the viewer is doing is pulling prescription information from the pharmacy network, which includes multiple pharmacies, into this viewer window. So you have to go through to kind of figure out exactly what the patient is taking. So if we look at prescription status, we can see here on the morphine SR30, it's an active status. So an active prescription means there's refills remaining on the prescription, or there's no refills remaining, but the day supply on the dispense hasn't passed yet. So it's still dispensable because there's refills remaining, or if there's no refills remaining, it's still an active prescription because the dispense day supply hasn't passed. So technically the patient is still taking the medication. If we look at an aborted prescription, and again here now in the morphine SR30, an aborted prescription has been inactivated by a pharmacist and is no longer fillable. But the dispenses under the prescription may still have taken place prior to it being aborted. So if we now click on the second morphine SR prescription, the status is aborted, but when we go to the dispense status, these are completed. So these dispenses occurred on September 4th, October 5th, and November 1st. The prescription was aborted at a later date. The patient received these medications. So we want to make sure we're not confusing an aborted prescription with an aborted dispense. A prescription can definitely be aborted, and they're aborted a lot of times at a pharmacy when a new prescription comes in for the same drug at the same strength. The pharmacy will abort the old prescription and put on the new prescription. So an aborted prescription still means dispenses could have occurred. And then a completed prescription, if we click on, I'll go to the hydromorph prescription here. We can see this one has a completed status. So what a completed prescription means is all the refills have been depleted and the day supply on the dispense has passed. So if we look here, there's no refills remaining. Quantity remaining is 0. And the day supply was 3, and it was dispensed on August 23rd. So basically, this prescription became completed on August 26th. The other instance where you may have a completed prescription is if it's the prescription has expired. So all prescriptions expire after 365 days. So even if there's refills remaining, if it was prescribed more than a year ago, the prescription is now expired and the status becomes completed. Another status, which I don't have here, and you won't see that often, is a suspended prescription. And that means the prescription is temporarily not dispensable. A situation you might see that is if a patient is on daily dispense of methadone and the pharmacy is made aware that they're now admitted to hospital, they're an inpatient, the pharmacist may suspend the prescription until the patient is discharged and then reactivate the prescription so that it's not being dispensed through like a batch fill every day while the patient is admitted. A lot of pharmacies, I don't believe, use the suspend, but you may see it from time to time, and that just means the pharmacies just basically put it on hold for a reason and they can reactivate it at a later date. So our dispense status, we basically have aborted. So if we go to this oxycosat, we can click on this active prescription. We can see an aborted dispense. This is when you know the patient didn't receive the medication. An aborted dispense means the pharmacy has reversed that dispense. So on January 6th, they filled the prescription, and then for whatever reason, they decided, oh, actually, we shouldn't fill this medication. They aborted the dispense. The patient didn't get it. And then we can have an active dispense. If we go into morphine, we can see here morphine SR30, the status is active. That means the prescription was dispensed, but hasn't been picked up yet at the pharmacy. So it's basically waiting there at the pharmacy for the patient to pick it up. So while a status of active remains, the quantity remaining doesn't reduce. So we can see here, prescribed quantity 180 on this morphine SR30, and the quantity remaining is 180 until a pharmacy does the pickup, which means the patient came in and took the medication, the quantity remaining doesn't deduct. And that's why sometimes we get a little bit of confusion. A prescriber may look and see that the quantity remaining is still there, but the patient comes and says, the patient says, I don't have any refills remaining, and it may be the pharmacy missed the dispense. And if you go into like a prescription and you see multiple dispenses and they're all active and they kind of seem to be on time, if there was a dispense here on December the 5th and a dispense here on November the 5th, all active, it's extremely unlikely that this patient has 3 months worth of morphine SR sitting in the pharmacy. I would say give the pharmacy a call and say you haven't done your pickups. And that's why the quantity remaining is not showing correctly there. And then our completed, if we go on the morphine 15, this one right here, status is completed. That means the patient has come in, they've picked up their medication, and the pharmacy has done the pickup. So it's been completed. And that's your other status, the completed status. So I know that's kind of a lot to take in, and it is definitely a bit confusing. There is a help tab in HEALTHe NL that kind of explains the different statuses. I think not sure exactly where it is, but there is like a little.
Is it maybe not there because you're in the?
It could be because I'm in staging. Yeah.
Yeah.
But yeah, if you, it's a good idea to kind of go into HEALTHe NL and kind of just, when you kind of click through it, look at the different statuses, and kind of review them. And like I said, at the same time, if you can you can even print off that little sheet to kind of have as like a cheat to know to kind of the different statuses. But the big thing that I stress about statuses is prescription aborted certainly doesn't mean that the patient didn't receive the medication. So when you look here, you see 2 aborted prescriptions, you're thinking, oh, the patient only got 1 morphine SR prescription, but that's not true. It just means it's no longer dispensable at this time. Doesn't mean that it wasn't dispensable in the past and that dispenses didn't occur.
Yeah, you're right. It is a lot of information here, Jeremy. And on me, I'm not a nurse practitioner, so seeing this information now is it's quite eye-opening for me. Especially with the different statuses and the clicking into the different medications and realizing that first window isn't giving you the whole picture.
Yeah,
and you need to click into it. Yeah.
Yeah, and that's a common misconception. Like that's not lots and lots of prescribers and dispensers really aren't sort of familiar with how to read kind of HEALTHe NL and how to navigate it to kind of get a patient's medication history out of it. And unfortunately, there is no quick, click on this and this tells me exactly what a patient is taking. That's really not possible. You kind of need to kind of click through it. But there are sort of ways when you get used to it, you want to look at the last dispense and you can say, okay, I can see it hasn't been dispensed for, a month or 2. I know they're not taking that prescription anymore because the last time it was dispensed was 2 months ago. So, once you kind of get used to it a little bit and you navigate it, it does become a little easier for reading and, pulling the information out a little quicker.
Yes. Perfect. Thank you, Jeremy.
Yes, and Jeremy, the monitor drug only tab will certainly help nurse practitioners, right, and prescribers to navigate.
Exactly. That really kind of takes out a lot of the sort of noise around there with all the other prescriptions. And then you could have multiple pages and trying to find just the monitor drugs. Patients can have extensive profiles that can be like, 2 or 3 pages of medications that you're trying to click through and trying to see, if they have. So just clicking on that monitor drugs, will definitely make it a lot easier to kind of condense it down.
Absolutely. And we're recording the session today. So, when nurse practitioners, are, at their office or at home and want to review it and having the pharmacy network up while they're reviewing it, that can help them as well.
Because you ticked off 12 months. What is the requirement that we need to look back on? Like, what does the Act say? And you may have already said that. No,
there is no requirement. It just says you have to review. It's going to default to 12 months, but there's nothing in the Act that says you must review 12 months worth of, profile or 4 months worth of profile. It's just that you must review the patient's provincial electronic health record.
Okay. All right.
Whatever you think is clinically appropriate to review, but there is no requirement for timeline.
Okay, perfect. Thank you.
Jeremy, anything else you wish to demonstrate there in the pharmacy network, or?
No, I think that's kind of it. Like I said, there's a lot there, just even in this medication profile tab. But if there is questions or concerns, there is a HEALTHe NL training team that you can reach out to if you need more information. But also feel free to reach out to me if anybody has sort of specific questions, with regards to monitored drugs and questions they might have on, reviewing the patient medication profile and that sort of thing. They can certainly feel free to reach out, and I'm happy to kind of review the viewer and best ways to kind of navigate it.
Perfect, thank you. And we have provided information to nurse practitioners through notes from the practice team, and also a direct email to nurse practitioners on the requirements for the prescription monitoring program. So, Jeremy, have there been any changes or trends in opiate prescribing since the Prescription Monitoring Act was passed?
Yeah, actually, there's been quite a few changes that we've seen. So the act was passed in 2018, and we have seen a trend in the number of patients receiving opioids for pain declining year after year. In 2019, an average of 15,788 patients per month received non-ODT opioids, so basically opioids for pain. And in 2022, that was down to 14,178 patients a month. And in 2023, we're down to an average of 13,838 per month. So we're talking almost 2,000 patients a month less from 2019 to 2023. And it's basically works out to be a 10% decrease overall over that time period, which is like a gradual decrease, which is what we want to see. We don't want to see like a drastic drop because then you would kind of worry about those patients who are on sort of chronic opioids and what's happening there. What we're hoping to see is, these acute opioid prescriptions, sort of like a drop in those. So, and that seems to be what we're seeing is a trend down. And at the same time, we're seeing the number of patients who are receiving opioid dependency treatment per month steadily increasing. In January of 2024, so just 2 months ago, we had 3,151 patients who received Suboxone or methadone in the province, and that's up from 2,293 in January of 2019. And so that's a 37% increase in the number of patients who are receiving opioid dependency treatment. And that's what we want to see. We want to see patients, we know that there's an opioid misuse, people who are struggling with opioid use disorder in the province. So we want to see those patients increasing. And then we're going to see patients who are taking it for pain decreasing, just because, they're going to be transferring from the, pain over to the opioid dependency treatment group. And we're seeing large growth in that. Not that that has anything to do with the prescription monitoring program. That has to do with the increase in access provided by the provincial ODT hubs. As part of that hub and spoke model, I think access to ODT in the province over that time period has significantly improved. So that's what's driving, I think, that those numbers there, which is fantastic. And something that was kind of we had seen that Suboxone this month was the first time Suboxone prescriptions actually passed methadone prescriptions for opioid dependency treatment. It's been about sort of half and half for the last 3 months or so. And prior to that, it was always, we had more patients on methadone than Suboxone. But in the last month, we actually seen more patients receiving Suboxone than methadone in the province. And that's a first time for that. And then since the program started, we've seen a significant reduction in the number of patients who are receiving opioids from multiple prescribers in that 30-day period. So that report we run on checking, to see sort of who's receiving multiple opioids from multiple prescribers. So for the 12 months prior to July 2018, and that's when the mandatory profile check was effective, we would see an average of 1,110 patients per month getting opioids from multiple prescribers. That's decreased about 40%, where we're consistently below 650 patients per month for the last 3 years getting opioids from multiple prescribers. And we're going to hit a plateau where we know for multiple reasons why patients may be getting opioids from multiple prescribers legitimately. If you don't have a primary care provider and you're using walk-in services or telehealth, those sorts of services. You may not get the same provider regularly, and patients, again, surgeries, emergency situations. There's lots of reasons why we're going to see, a certain number of patients kind of getting opioids from multiple prescribers. And I feel like we've kind of plateaued around that number of 650. Sometimes it's down a bit and sometimes it's up a little bit, but that's where we're kind of sitting. But it is a huge decrease from prior to the program starting. So.
Well, that's some great statistics that you provide us, and it seems as if the education that's been done by the provincial government on their opiate action plan, and having the prescription monitoring program and act in place has certainly helped to contribute to these, and having the hub and spoke model implemented in Newfoundland and Labrador has had some great success. So that's wonderful to hear. So thank you.
Jeremy, do you have any advice for prescribers when they are prescribing opioids for acute pain for opioid naive patients?
Yeah, so we know that opioid use for acute pain is a risk factor for patients then transitioning to chronic opioid use. And we know once we have patients who have chronic opioid use and then moving into opioid use disorder, it can be very difficult then to address those issues. So you want to kind of catch it from acute before it moves to the chronic phase. And there's a lot of patient characteristics that contribute to the progression from acute use to chronic use, but a lot of those aren't clinically modifiable. But there are studies that have shown that there's specific features of the initial opioid prescription that are strong predictors of progression to chronic opioid use. And that includes the number of tablets, the prescription length, and prescriptions for oxycodone. So this is where prescribers can make a difference when choosing to prescribe opioids for acute pain. So we want to remember when we're prescribing for acute pain, prescribe the lowest effective dose of an immediate release opioid for a quantity needed to cover the duration of severe pain and then reevaluate. And typically we're talking 3 days or less is sufficient. And more than 7 days is rarely needed. So you're looking at 3 to 7 days. But we find that using a discrete numerical cutoff, so the tablet quantity restrictions, are easier to work into a clinical workflow as opposed to like day supply limitations or MME. Because if you're looking at it and you're saying, okay, they can take 1 or 2 every 4 to 6 hours, and I'm prescribing X number of tablets, they can take X number in the day. How many days supply have I prescribed? It gets a little kind of, I don't know if everyone's going to take the time to do that calculation to say, have I prescribed 3 days supply, 7 days? So if you come up with like a day supply, if you regularly prescribe for, moderate, pain, a tablet quantity of 20 or 30, whatever, you want to work into your workflow, that's easier to kind of do than come up with a day supply cutoff. And studies have shown it's the number of tablets that's actually the largest sort of that corresponds best to patients who change from acute to chronic opioid use. And you see jumps when you go from 20 tablets to 30 tablets, and then 30 to 40 tablets. You even see a larger jump in sort of the percentage of patients that are prescribed this initial prescription, who then progress to chronic opioid use. So you want to counsel your patient that its short-term opioid use can lead to unnecessary long-term use. And that's why you want to, the opioid is going to be discontinued as soon as appropriate. And even for short-term use, they do recommend a taper. Now, if you said to a patient, I've given you 20 tablets, if you use 2 or 3, you know what I mean, you're not going to need a taper. But if you have a patient who's taking, 1 to 2 tablets every 4 to 6 hours for 3, 4 days, or even a week, you may suggest that they, they don't need a long extended taper, but even a taper over a couple days is a good idea to help them discontinue use. And you want to be wary of prescribing opioids to patients who ask for specific drugs by name. If they're asking for brand name only, if they only want specific generic brands, or they claim allergies to alternative drugs, these can be red flags for misuse or diversion. It certainly does not mean if someone's coming in and requesting a certain one that's oh no, this person is going to be selling this or something like that. But it's certainly a red flag, especially when they're requesting certain generic brands. We see with opioids in particular and other sort of controlled drugs, patients claim allergies to all of these generics except this one generic. You don't see that with blood pressure pills, diabetic pills. You don't say patients saying, I can only take APO, I can't take ratio. I shouldn't say you don't see, but you very rarely see. Where with opioids, we commonly see people saying, I only take this one, I can't take the other ones because. And like I said, it doesn't mean that there's diversion, but I mean, it's certainly a red flag and something you should take with caution when you have patients kind of requesting that.
Interesting. Jeremy, is there any opiate that you think needs more careful consideration before prescribing for pain?
Yeah, tramadol should not be considered a safer opioid with low risk of addiction and should not be considered a first-line treatment for pain. I think a lot of prescribers through marketing have been told that tramadol was a safer opioid than other traditional opioids. And its status as a weak opioid receptor agonist kind of masks this underlying risk regarding prolonged opioid use. We actually seen in studies a higher prevalence of tramadol prescriptions in patients progressing from acute opioid use to chronic opioid use. So if you're in a situation and you're thinking, I don't know if I want to prescribe Tylenol 3 to this patient, I'm going to go with tramadol, that's not a safer choice. Tramadol carries the same risks that other opioids carry, and I think that's often kind of not known. I think we've been told that tramadol is a safer option, but it really isn't. And it may actually be the opposite that, like I said, we're seeing patients, higher prevalence of tramadol prescriptions in patients who progress to chronic use compared to other prescriptions. And in addition to that, tramadol has SNRI, serotonin norepinephrine reuptake inhibitor-like effects in addition to its opioid effects. So in addition to CNS and respiratory depression, it poses additional concerns, including seizures and serotonin syndrome. And the risk of serotonin syndrome with tramadol can be increased when it's used with other serotonergic drugs, such as antidepressants, very commonly prescribed drugs. I mean, we see many patients on antidepressants, so tramadol really isn't a good choice if a patient's on an antidepressant. And tramadol is also increases the risk of seizures. And this is an issue for patients who may be on an antidepressant that inhibit CYP2D6 and reduce seizure thresholds. And that would be bupropion, venlafaxine, and other SSRIs. They're going to be at increased risk of seizures when you combine that. Or patients at risk from alcohol withdrawal, they're going to be at an increased risk of seizures. So tramadol, again, is not a good choice in that patient population. So because of these drug interactions and the fact that it really isn't a safer opioid, tramadol isn't really a great choice for pain treatment. I would think there's better alternatives to tramadol.
Okay, thank you. Gee, some interesting information that you've given us today. Thank you.
Absolutely. So, Jeremy, we didn't have any more questions. Michelle mentioned that information related to the prescription monitoring program went out in the notes from the practice team. And as well as, Michelle, I believe you sent an email directly to nurse practitioners as well. So check your emails, check your spam, just in case it did go to your junk email. I just wanted to thank you, Jeremy, so much for that great presentation and lots of really good information for our nurse practitioners and you know for registered nurses as well, just to be aware of that program. And yeah, so thank you.